By looking back on recent public health history of the hysteria surrounding outbreaks and potential epidemics like Ebola, SARS, bird flu, and more, we argue that fear-mongering has an overall negative impact on community health. Our arguments against fear-mongering ought to be considered as health professionals and policymakers today are faced with having to address the Zika outbreaks now impacting communities worldwide. But considering all of the other pressing public health issues of our day, is the Zika news coverage currently bombarding our newsfeeds proportionate to its seriousness? Media plays a key role in fueling societal hysteria surrounding disease. Journalists and news agencies, motivated by financial gain, have utilized panic as a tactic for garnering public attention. However, fear-mongering ultimately harms community health. We prove this argument based on the following. 1. Claims regarding what's new and emerging are often unfounded. 2. Resulting emergency responses take away from efforts toward long-term sustainable solutions. 3. Health services are taken away from areas where they are still considered necessary. 4. Communities and cultures become stigmatized. And B. Fear-mongering is not necessary to properly react to public health threats.
Many important themes were referenced in class, and two applicable ones are contingency and wealth and health and poverty and illness. Contingency in this context is regarded as the halfway point between randomness and inevitability. Things happen under circumstances and human choice, but not totally free choice due to constraints and circumstances. Michael Osterholm would agree with this, as he has correctly predicted the outbreak of diseases in the past. These new diseases were foreseen, and though maybe random in location of occurrence, they were bound to happen. In regards to wealth and health and poverty and illness, new diseases are not new to the impoverished populations of the world and have experienced these illnesses. They become new when exposed to the Western world that never had to deal with these illnesses before. The idea of new modes of transmission comes along with the idea of new diseases. Modern feats such as air travel have been blamed for the intercontinental spread of new diseases. However, diseases have spread worldwide for centuries, invalidating this claim. This concept is not new, as ships have been found to spread diseases in the past. There are simply newer ways of travel that carry out the same result. An example of a new disease not actually being new is Ebola. In 2014, news about Ebola hit the United States and panic ensued around this new disease. However, its first reported outbreak was in 1976, with many other outbreaks before 2014, as noted in the graph. Its mode of transmission through bushmeat has also been seen elsewhere. The reaction of Americans to this disease emphasized the wealth and health theme, as other countries had been dealing with this disease for years, but it did not blow up until a country with money and status behind them got a hold of it. In regards to the contingency argument, this disease could have been seen as due for another outbreak. The inevitability argument and the outbreak occurred because of the human choice to eat bushmeat, though not totally free choice, since it could have been regarded as the only food option in that area. Another false claim of a new disease came with the mid-2000s outbreak of mad cow disease. The initial discovery of the disease came in 1986, with the major outbreak occurring almost 20 years later. In this case, the wealth and health is a non-entity, as the outbreaks occurred in Western nations. However, contingency is very prominent because it was somewhat random for such a deadly illness to break out in places with strict food regulations, yet inevitable due to the fact that these regulations allowed for feeding cows poor quality food and allowing their meat to be sold to humans. Zika, the current new and emerging disease, was first discovered in 1947 in Uganda, with the first human cases detected in 1952. This current outbreak is an example of contingency, neither random nor inevitable. It was the disease's time to emerge again. To go along with this, the transmission of Zika as a new disease is also incorrect, as Zika has been transmitted by a vector like many diseases before it has been.
As a result of the panic by the media about the newest disease epidemic, money is invested in short-term solutions that are often ineffective. This has been demonstrated in the response of Ebola, mad cow, and now Zika. For example, Obama's response to Ebola crisis of constructing clinics to treat Ebola patients in Liberia was misguided by the fear surrounding reporting on Ebola crisis. This fear led to expensive investment in clinics that were too late to aid in containing the epidemic, and they have gone unused. Paul Farmer explains that the health system itself needs to be the method of intervention because if this country in which Ebola was spreading had the properly trained staff, supplies, and equipment, and health system to deal with the outbreak, then epidemic like one in 2014 could be easily contained. In the case of mad cow, the media exaggerated the outbreak to cause fear, resulting in only a few people actually being saved and a devastating of the beef industry economically. Even vaccine researchers have stated that a vaccine for Zika will not be created in time to offer any aid, and so structural intervention like those that improve standards of living and housing conditions should be implemented in its place. Virchow noted epidemics are symptoms of the socioeconomic reality of a country, and the Ebola epidemic exposed the precarious conditions of health infrastructures in sub-Saharan countries. So instead of jumping to conclusions based on media amplifications, we need to take a step back and evaluate the larger problem with the health system that the diseases point to and develop long-term solutions that get at the root of the problem. This way, we will not only be able to more effectively allocate funds but also prevent future epidemics.
Hysteria surrounding potential epidemics inevitably leads to an increase in the distribution of public health resources in order to ensure that one particular disease does not spread. The induced fear is oftentimes disproportionate to apparent risk. These sudden increases in expenditure to contain and treat one particular disease is induced by fear rather than science and logic. Such has been the case of the recent Ebola and H5N1 virus outbreaks. While some might think better safe than sorry when public health professionals are forced to face potential threats like these, it is important to realize that there is a limited amount of public health resources. Therefore, it is important not to close off our peripheral vision and lose focus of other public health threats when faced with the unknown. Known killers like malaria, HIV and AIDS, lower respiratory infections, and tuberculosis cannot lose the medical attention that they deserve during times of hysteria, when one supposedly new and emerging disease becomes more popular amongst news headlines. Otherwise, funding and other resources are taken away from areas that still deserve attention, if not more. We have seen this happen when the unprecedented panic surrounding Ebola during the 2014 to 2015 outbreak resulted in a decrease in the health services usually available to treat malaria, HIV and AIDS, and tuberculosis in West Africa. As a result, the community suffering and mortality rates from these other diseases increased. The healthcare systems in Guinea, Liberia, and Sierra Leone were exhausted in order to address the panic surrounding Ebola. This figure compares the total mortality rates of malaria, tuberculosis, and HIV with malaria alone, tuberculosis alone, HIV alone, and Ebola alone during the 2014 to 15 Ebola outbreak, while the treatment coverage for malaria, tuberculosis, and HIV decreased. Graph A depicts the mortality rates in Guinea, Graph B depicts the mortality rates in Liberia, Graph C depicts the mortality rates in Sierra Leone, and Graph D depicts the total mortality rates in all of these countries. All four graphs illustrate a clear increase in mortality rates of malaria, tuberculosis, and HIV as health coverage is diverted away from each. As treatment coverage for malaria was decreased by 70% in Guinea, the deaths from malaria were more than triple those caused by the entire Ebola outbreak. This table depicts the deaths from malaria, HIV and AIDS, and tuberculosis that are considered attributable to the sudden decrease in health services. The diversion of health resources induced by the panic surrounding the Ebola outbreak caused a total of at least 6,269 new deaths in Guinea, 1,535 new deaths in Liberia, and 2,819 new deaths in Sierra Leone.
Fear-mongering is counterproductive and ineffective because it spreads unnecessary panic in the communities. It generates stigma over a group of people linked to an epidemic. For example, during the SARS epidemic crisis in 2003, Chinese immigrants in New York were stigmatized because they were deemed as carriers. According to Laura Eichenberger, news media advised people to avoid Chinese food in Chinatown in New York City, although studies found that there were no a single case of SARS reported during this epidemic. This scapegoating was not limited to the Chinese immigrants, but also to the residents of Chinatown in New York City. The studies on media coverage of SARS epidemic in 2003 also found stigmatization of Asians not only in the US but also in Europe. And as a result of this stigma, Asians suspected of carrying SARS receive poor medical care. These are unnecessary human consequences of fear mongering. Furthermore, fear-mongering weakens social cohesion rather than strengthening the communities in times of epidemic crisis. By constructing an epidemic as one group is problem and a threat to the others, the media dehumanize a particular group of people and contribute to shape the perception of the other. As seen in the documentary on HIV/AIDS, Asian immigrants were portrayed as carriers of HIV virus, and this had deep socioeconomic implications in the Asian community in the US. Similarly, during the Ebola health crisis in West Africa, Africans were blamed for their cultural practices, such as funeral rituals and consumption of bushmeat. Stigmatization of the Ebola victims shaped its social response to this health crisis, but most important, it shaped public health measures such as excessive quarantines of travels coming from this region of the world, because politicians respond to the public concern. Fear mongering is a product of media construction, but is not the most effective response to epidemic crises. Health literacy has proven to be an effective tool in preventing and lessening the burden of diseases. For example, when cholera epidemic first hit my village in Calikis in Guinea-Bissau, many people died. Funeral rituals, even for those who died from cholera, were performed normally because people did not know what cholera is. Nevertheless, in the second cholera epidemic, a few people died because individuals were educated about the symptoms and modes of transmission of cholera. And today in Calikis, all traditional ceremonies, including funeral rituals, are suspended during cholera epidemics in Guinea-Bissau, even if there is no case of cholera reported in the village. This demonstrates the power and effectiveness of health literacy. Stigmatizing the victims of cholera in Calikis would not have produced effective results as health literacy did. It would have not convinced my people to suspend indispensable and sacred traditional rituals to honor the passing of a loved one in a cholera epidemic. In fact, it would have sparked a stiff resistance from the community members. Rather than fear mongering and stigmatizing the victims of epidemics or attacking their cultures, the new media should adopt a pedagogic role and provide health education that can improve the public's understanding of the risk factors, the symptoms, and modes of transmission of a disease, but also to calm the public when there are no reasons for alarmism, as it was in the case of Ebola crisis.
With disease outbreaks and epidemics, there are associated direct costs, such as the number of lives claimed and the various resources allocated to the public health and medical sector for disease containment and treatment. However, there are also indirect costs of disease due to the disruption of the economic activity. Implementation of certain prevention measures can consequently profoundly impact a country's economy. For example, countries with high tourism and travel activities see a drastic impact with travel bans and restrictions, even if they are not directly affected by the epidemic. Agricultural industries are affected when food transportation, movement of people or workers are limited. On a smaller scale, businesses also see impact when fear of transmission restrict consumer behavior. Some may argue fear-mongering is a key tool in effective disease control, but we have to question whether these measures are truly effective or necessary because of the economic costs associated with them. For example, the SARS disease infected less than 10,000 individuals and killed less than 1,000. But what was the economic cost of the disease? Scholars estimate anywhere from $30 billion to $100 billion in economic impact of the disease. Similarly, the mad cow disease outbreak in the early 2000s cost the U.S. beef industry $3 to $4 billion with disrupted trade. The number of confirmed deaths from the disease was 227. In light of the high economic burden that countries may face as a result of these outbreaks, many scholars warn against overreaction that is largely influenced by the media that may overblow the issue. Such was the case with SARS when the media excessively covered the disease and reported inaccurate information when the nature of the disease was largely uncertain. Complicating the issue, public trust in the government and public health officials in these situations are low, as revealed by opinion polls during the recent Ebola epidemic. Only 31% of the public reported trust in the U.S. public health officials on telling accurate information about the virus. During these confusing and panicked moments of disease epidemics, the media limits effective measures in controlling fear. As a result, exaggerated or unneeded measures may be implemented that may have high economic costs.
In conclusion, we must consider these concepts related to fear and make informed decisions based on lessons learned from previous outbreaks. There is currently much uncertainty surrounding Zika, but being aware of the impact of fear can allow for more effective solutions to be implemented and decrease the negative impacts of diseases we are not familiar with.